All right, the last disorder we're going to look at and how therapy approaches it is depression. So attached you'll find the depression chart, just like you did with post-traumatic stress and bulimia. Go through and list information we learned in Unit 6 by looking at the etiology and the symptoms. Again, you're not putting your notes here, you're just synthesizing the notes, summarizing and just pulling out the core key terms, concepts that you need. So review your notes, give me the biological, psychological, social causes of depression, and then give me the affective, the behavioral, the cognitive, the somatic symptoms of the disorder. And then whenever you're ready, you can continue with this lecture. Right, with the biomedical approach, most likely we're going to use antidepressants to help with depression. We know that depression's been linked with a lack of serotonin. Either your body naturally doesn't produce it enough, or because of the depression, your body lowers its production. So what we could do is give you medication that'll help to slowly increase the amount of serotonin that's available. Right, so most depressants, they're antidepressants, they're called SSRIs, selective serotonin reuptake inhibitors. So you can see in this picture here, the reuptake process is where the neurotransmitters go back into that axon terminal. But if the drug blocks that channel, well, then serotonin can't get back into the neuron. It's stuck in the synapse, which means it'll bond again and again to those receptor sites, sending out the happy, content feeling that serotonin's responsible for. It's a slow process, and so every time the neuron releases serotonin, more and more of it will end up being blocked within that synaptic gap. So eventually it'll reach more like normal, bunny quotes, normal levels compared to those that don't have depression with depression. Right? It's very effective, especially if you have major depressive disorders. With major depressive, it's most commonly linked with some chemical imbalance within the brain versus maybe like dysthalmic disorder, which is a temporary form of depression or a mild form of depression. Seasonal affective disorder, which again is a like seasonal cyclical type of depression. Those tend to be more environmentally based and not necessarily triggering by the chemical imbalances. But if you have major depressive, that is heavily linked with brain chemistry. Right? If we want it to work faster, we find that sometimes it's more effective than the individual approaches. Right? It gives some autonomy back to our clients because they can do this at home. It's part of just a normal medication regime that anybody else would be following. Regimen, not regime. And so it gives them autonomy in the sense where we can recover faster with these medications within our systems, rather than just doing talk therapy alone, where we wait for the mood to improve and then hopefully our body then eventually increase the serotonin levels. Right? This is going kind of straight to the cause and fixing the issue there. Right. However, there are some negative side effects linked to these SSRIs. There's cases of insomnia, vomiting. It can impact insomnia. It can mess with the sexual response cycle. And one of the biggest negative side effects is that it has an increased risk of suicide. It's true, but there are some issues around that. All right, if we're testing a drug, we need to find a population of people who have the disorder to see if the drug helps the disorder, which means this population already has a symptom of self-harm thoughts or suicidal tendencies. Right? So these side effects, anything that happens to the participant has to be listed on the labels. And so all the participant groups where SSRIs have been tested, they've experienced these symptoms. And we don't know if maybe it could be due to the effects of the drug, or it's just due to the individual's inherent tendencies. Now, through consistent testing, because we've been testing them over many decades by now, these usually show up. So we can most likely say that these are probably due to the drugs. And so they do carry a black box label because of that high risk of suicidal tendencies. What we also find is that these drugs might not actually be as effective as we want to think they are. Right? All the ones that have been approved by the FDA, they have passed double-blind procedures. Extra credit point in your private comment section. Tell me what are double-blind procedures and why these are good things for researchers to use. Right? But the FDA has made sure that all the drugs on the market have passed double-blind procedures, showing that the drug is better than the placebo. However, it's not that much better than the placebo. And in some trials, the placebo actually outperforms the drug without the negative side effects. Right? So these drugs that are heavily marketed, are they actually there with the main goal of helping the patient? Or are they there to help gain more money for the drug companies? All right, we can also use exercise to get the same benefits without experiencing the negative side effects. When you exercise, your body releases endorphins. Endorphins make you happy. It boosts the serotonin supply within your brain. And so we can encourage our depressed patients to exercise, and then it'll get the same serotonin boost within their brain. Also, unfortunately, we know that one of the symptoms of depression is lethargy, so getting someone to be motivated to exercise is already a difficult battle. So there are some positives and negatives linked with using these biomedical approaches. Right. What we could also try is electroconvulsive therapy, ECT. This one's a little bit more controversial, and so it's usually used with more extreme forms of depression, like major depressive disorder. How it works is you pass an electrical current through an anesthetized patient and to trigger a small seizure within the brain. You undergo these procedures a few times a week for a couple of weeks, and again, it depends on the patient, the doctor's treatment plan that they're trying to follow. But the idea is that these electrical currents will trigger a boost of all neurotransmitters within the brain. And then when it resets, when it goes through that reuptake, it kind of resets the brain the same way when you reboot a computer, it resets all the problems within the computer. They've advanced so far that they're actually at-home ECT units you can have. For example, there's it's called A-Stim, and it's just little tiny electrodes you would attach behind your ears, and it has a control console that you can control yourself, and so it feels like a light tingling or an intense tickling sensation. And so in some cases, this can actually be done at home without needing to be anesthetized or go to the hospital for a more rigorous regimen. It can be something that's mild, done at home, that isn't as fast at working, but it doesn't have some of the negative side effects. Some of the very bad negative side effects is memory disruption. It can lead to the inability of either retrieving memories from just before the procedure or the ability to encode information just after the procedure. So a lot of patients say that the hour right before and after, everything's fuzzy and they can't remember things linked to those moments. In rare circumstances, sometimes they've lost memories from the past, and so there are chunks of time that are just lost to them and they are irretrievable. But it is more effective where the drug regimens don't work. It's very effective with these other affective disorders. So, for example, bipolar type 2, those blended manic depressive episodes. And so it does have markedly good benefits, even though there are some negative side effects that you have to be aware before you sign off on going through the therapy. All right, so take a minute and apply these biomedical approaches to the etiology, to the symptoms of depression. All right, again, try to make a strong link by doing this. It'll address this specific problem. So go through and come up with a treatment plan for the causes and or symptoms of depression. All right, the next thing we could do is use individual therapies. All right, and Aaron Beck is a big cognitive therapist who's very influential with helping depressive patients. All right, we talked about Beck's therapy last year in AP Psychology, so some of this will probably be trigger some memories for you. What Beck believes is that the reason why patients are depressed is because they interpret their environment negatively. They have these self-defeating biases, these low self-esteem issues that lead them to interpret reality as being darker and more negative than maybe it actually is. So remember back in Unit 6, those 3 symptoms that Ellis looked at, the symptoms of a self-defeating bias, the fact that these consequences have lasting rippling effects throughout times, and that it's a never-ending consequence. All right, well, those negative schemas are what's leading into the depression. So if we can change these automatic thoughts, well, maybe we can break that depressive cycle and help our patients get better. So what Beck's cognitive restructuring therapy does is first, it tries to help the patient identify those negative thoughts. All right, identify when those thoughts are pessimistic, when they're self-directing against themselves. and then look at how these negative thoughts are actually impacting the depressive state. Because you're thinking this, it's increasing how poorly you feel, and therefore exacerbating the symptoms and exacerbating the disorder that you're dealing with. Right? Then they'll address that these thoughts actually have no basis in any reality. It's illogical. Right? Sometimes they'll be very confrontational and say, nope, that thought is wrong. Nope, that thought is stupid. Right? Or sometimes they'll coach the client along to come to the conclusion themselves that this doesn't really make sense. Right? So this one tiny score is not going to lead to me being homeless. That's illogical. All right, and by recognizing those negative thoughts, how it's feeding into the disorder, and recognizing that they're illogical, maybe we can come up with a realistic interpretation, a new change that we can make. And so by redirecting those thought patterns, by showing the illogical elements to the client, hopefully they can adjust those negative schemas that they have and have a more positive outlook. And by having that positive outlook, it'll help them overcome their depressive state. We could also try cognitive behavioral therapy. All right, it's building on Beck's work by trying to add the behavior modification elements into it. All right, we know that our behaviors are in response to our thoughts, and they can reinforce those thoughts that we have. And so if we can also address the behavioral complications, so for example, if I am depressed and I'm not getting out of bed, well, that behavior allows me to stay in bed and dwell on those negative thoughts, which makes the depression much worse. And so we can also look at the behaviors and hopefully change those to maybe impact those thoughts and help alleviate the mood that's kind of circulating and spiraling down. All right, so what they find is that they will correct these negative thinking patterns. We have arbitrary inferences. Oh, I have the worst luck. People are out to get me. There's selective abstractions. Oh, I suck at this game. There are overgeneralizations of I have no friends, or an exaggeration that I'll never get a job. We tend to personalize things. They all hate me. Or dichotomous thinking. It's you're all against me. Right? We have these negative thought patterns, and the goal is to flip them, adjust them to be more positive. Because if I have a positive change in thoughts, that'll impact the behaviors that I have. All right, so for example, my overgeneralization, if I believe that I have no friends, well, the behavioral reaction to that thought is I'm not going to call or text or reach out to those that I know. Right? Well, it's not that you have no friends. You might not have as many as others, but you do have some. Or maybe they don't care as deeply as you think that they should, but you can work on building that relationship, making it better. And so by changing the interpretations of these thoughts, it'll change the way that our behavioral responses are. Right? Now I'll never get a job, that over-exaggeration from one poor mistake within the interview. Well, no, keep going out there. You can do a lot of things to still leave a positive impression after maybe one small blip in the interview element. So looking at your resume, recognizing that you've done really well in the past, recognizing the strengths and the skills that you've developed, right? And even if you don't end up getting this one job, at least you have the experience and know what to do better next time, right? So there are these steps that you can take. And so what cognitive behavioral therapies look at that interplay between your thoughts and the behaviors. And if you adjust one, hopefully the other will fall as well, and it helps things get better in the long term. All right, we like this because it allows for our meta-awareness. You can think about thinking, which means there's very low relapse rates. Because you've been taught the skills of assessing and redefining your thoughts, makes it easier to recognize these negative, intrusive thoughts in the future and hopefully prevent them from derailing your positive behavioral pattern. However, people argue it's more reactive than proactive. I have to wait for the bad behaviors. I have to wait for the bad thoughts. And so it puts your client kind of in a more dangerous state rather than being proactive and preventing the bad things from happening from the beginning. All right. We also know that maybe our way of measuring how effective it is already biased. If my client leaves, I assume that they've gotten better. And if they never come back, I feel like they're still cured. But I don't know if they've gone to another therapist, or maybe they're still dealing with these problematic issues, but they just don't feel comfortable talking about it anymore. And so they're dealing with it on their own, but still have the disordered behaviors. And so there are some problems with tracking the success rates of these cognitive behavioral clients, because once they leave your office, we really don't know what's happening with those clients anymore. All right, so go through and address those individual approaches and how would they fix either the etiology or the symptoms of your disorder. Right? Go through and add that to your treatment plan, and then whenever you're ready, pick back up with this audio lecture and continue on. All right, the last thing we could do is we could address our group therapy. All right, we looked at this within bulimia. We know that there is instability in relationships could lead to the development of disordered behaviors, and that tends to be common with depression. All right, we know if it's a problematic family unit or an unhappy marital couple, well, people within those family relationships, people within that marriage relationship, they're at a greater risk of developing depression. So if we can address the family problems, address the marital problems, and what issue within that relationship is unstable, maybe we can have both patients, both clients be on a happier field, and therefore lower the risk of them potentially developing depression, or help them fix the depression that they might have already developed. We know that it's much more cost effective than our individual approaches. It tends to be more effective in the sense where we have greater accountability. If I'm addressing a couple or a family, well, if they all come together and one person stops, well, then I have a better idea of why that wasn't effective for them and things that we can address and change. And some people argue that it's more effective because it's a combined effort. Both people are working through this. All right, so the Toslin and Cipron study actually interviewed people who had gone through group therapy and then interviewed people who had gone through individual therapy, and then looked at the positive and negative feelings they felt about the therapy processes. And what they found is that those interviewed from the group therapy, they had more positive attributes compared to the individual therapy analysis of what they were getting out of those therapy options. Right? Obviously, there might be a flaw within the data that we're collecting here because it's all self-reported. And if you're doing group therapy and there's multiple people there giving the responses at the same time, there's the conformity element we get with our interviews. But it does show that there is some evidence saying maybe group therapy is more valuable than potentially those individual approaches. Right? What allows group therapy to be the most helpful is we have to address these three characteristics and how are they controlled for. Right? There's a lot of confounding variables in group therapy. I don't know the level of the depression that they're dealing with. I don't know the ability of the therapist, the leader of the group, and their ability to empathize. I don't know the dynamics of the group and how well they get along with each other or isolate from each other. And so if we can try and control for those groups, it allows us to trust the data coming out of these group therapy interviews more so. All right, so what's the group cohesion like? How similar are they all together? Are there any out groups or out individuals that aren't as accepted within them? Right, the more cohesive the group is, we find the better it functions and therefore the more effective that therapy is. Right, the exclusionary element. Are there some participant types that are speaking up way too much and don't allow other people to talk? Or is there just because there is a lack of cohesion, those out-group individuals aren't as accepted. They are silently judged or openly judged when they choose to share with the group. Do we trust the group, or we trust them to keep our names confidential? That's a big proponent of Alcoholics Anonymous, Narcotics Anonymous, that these people remain private, confidential, and the hope is that your names aren't released to the wider community. Do I trust the people in this meeting, in this room right now, to actually protect my identity and not share the stories that I'm sharing here? Right? And can you form a relationship with that therapist? Is it an empathetic relationship? Is the therapist one of us, or are they outside of us observing us? Right? So these different variables will impact how effective the therapy is. Right? Sometimes with a good group cohesion, you need the therapist to be that outsider to help regulate things, versus sometimes you need a more empathetic leader who's one of us because it helps us feel less excluded and it helps us believe in that confidentiality. And so these variables all kind of impact how effective we think the therapy will be in the long run. And it's something we need to look at whenever we evaluate studies done on group therapy effectiveness. All right, so this is the last thing you have to do. Go through and apply those group therapy approaches to either the etiology or the symptoms of depression. What specific concept or term do you see on the left that your right side will be able to fix and address? All right, once you've finished with that, do the closing reflection question, and then you're done for the day.